Subarachnoid hemorrhage is bleeding into the subarachnoid space, most commonly due to rupture of a saccular berry aneurysm. Other causes include arteriovenous malformations, dural fistulas, intracerebral hemorrhage extension, and paramesencephalic venous bleeding. Saccular aneurysms are present in approximately 2% of adults and account for most non-traumatic cases. Aneurysmal subarachnoid hemorrhage has a mortality of around 35%, with 1/3 dying before reaching hospital. If untreated, the risk of rebleeding is 20% within 2 weeks and 30% within 1 month. Larger aneurysms greater than 10 millimeters carry higher rupture risk, while giant aneurysms above 25 millimeters have up to 10% annual rupture risk. Most aneurysms occur in the anterior circulation, especially the middle cerebral artery and internal carotid artery. Pathophysiology involves weakening of arterial walls at bifurcations due to loss of elastic lamina and thinning of the tunica media. Rupture typically occurs at the aneurysm dome, leading to sudden blood release into the subarachnoid space. The classic presentation is a thunderclap headache described as the worst headache of life with abrupt onset. Associated symptoms include neck stiffness, vomiting, photophobia, and altered consciousness. Neurologic deficits such as hemiparesis or aphasia may occur due to associated ischemia or hematoma. A sentinel bleed may present as a sudden, unexplained headache days before a major rupture. Cranial nerve findings, such as third nerve palsy with a dilated pupil, suggest a posterior communicating artery aneurysm. Severity is graded using scales such as Hunt and Hess and the World Federation of Neurological Surgeons scale based on Glasgow Coma Scale. Ray rupture is a major complication with high mortality if the aneurysm is not secured early. Hydrocephalus may develop acutely causing coma or chronically causing gait disturbance and cognitive decline. Delayed cerebral ischemia occurs between 4 to 14 days due to cerebral vasospasm. Hyponatremia commonly occurs due to cerebral salt wasting, mediated by natriuretic peptides. Non-contrast computed tomography scan is the first-line investigation with over 95% sensitivity within 72 hours. If computed tomography is negative, lumbar puncture should be performed to detect xanthochromia appearing after 6 to 12 hours. Definitive vascular imaging includes computed tomography angiography and 4-vessel cerebral angiography. Cardiac changes such as ST abnormalities, T-wave inversion, and QT prolongation may occur due to catecholamine surge. Management goals include preventing rebleeding, controlling intracranial pressure, preventing vasospasm, and treating complications. Definitive treatment includes surgical clipping or endovascular coiling to secure the aneurysm. Early management includes airway protection, blood pressure control with systolic target below 160 millimeters of mercury, and intracranial pressure control. Nimodipine 60 milligrams orally every 4 hours is used to prevent vasospasm and improve neurologic outcomes. Treatment of vasospasm includes induced hypertension, euvolemia, vasopressors, and endovascular interventions such as angioplasty. Hydrocephalus is managed with external ventricular drainage and shunting if chronic. Hyponatremia should be corrected with saline and salt supplementation without fluid restriction. Survivors often have long-term cognitive and neurologic deficits requiring rehabilitation.